Hey, thanks for stopping by today. Our topic of discussion is capnography. So sit back, relax, and let's learn. Health services across Manitoba are provided in facilities on the original lands of the First Nation, Inuit people, and on the homeland of the Métis Nation. Manitoba's health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation. This presentation is intended as general information to broaden the knowledge base and inform practice of paramedics across shared health. The goal is to ensure paramedics can utilize the knowledge gained and incorporate it into their daily practice. Everyone's pretty familiar with pulse oximetry and its instant feedback provided about oxygenation. The airway, breathing, and circulation, the ABCs of a patient can rapidly be assessed using the capnography waveform and end-tidal carbon dioxide values. So today we will be looking at the instant feedback provided by waveform capnography and the information provided about the patient's ventilation, perfusion, and cellular metabolism. First, going through CO2 and how it's produced and expelled from the body, things that go wrong, how we can measure and read EtCO2, and how to apply end-tidal to different pathologies. So our first question, what is carbon dioxide? It's a colorless gas. It's a single carbon atom and two oxygen atoms. And it is a waste byproduct of aerobic metabolism, which is removed from the body through respiration. Carbon dioxide plays various roles in the human body, including regulation of body or blood pH, respiratory drive, and the affinity of hemoglobin to oxygen. Fluctuations in CO2 levels are highly regulated and can cause disturbances in the human body if normal levels are not maintained. This is a body process that converts food energy into usable energy and in the presence of oxygen. So how does this happen? It's Krebs cycle. We're going to stay away from that. So simply put, when the body is well oxygenated, combustion occurs and carbohydrates, amino acids, and fats are burned up. They produce adenosine triphosphate, or ATP, which is a principal source of cellular energy, water, and carbon dioxide. In the presence of decreased perfusion or decreased oxygen delivery to the cells still produce ATP, but through anaerobic metabolism, or lack of oxygen. This is the combustion of carbohydrates in the absence of oxygen, occurring when oxygen is unable to be properly diffused into the bloodstream and therefore cannot reach tissue cells. This process will produce lactic acid instead of carbon dioxide and water. So now that we've seen how CO2 is produced, what does the body do with it? We know it can't stay in the body, so it has to be transported out of the body somehow. The simplified answer to the question is that blood carries CO2 to the lungs. CO2 then goes down the concentration gradient into the air within the alveoli, which is then exhaled into the atmosphere when we move volumes of air out of the lungs. For a little extra reading, at some point look at Henry's law and Dalton's law, two pals that work together to diffuse gases across the alveolar membrane. And to summarize, the cells make CO2, the blood, via cardiac output and circulation, carries that CO2 into the lungs. CO2 then moves down its concentration gradient into the alveoli, and the physical act of exhalation emits the CO2 into the atmosphere. So we need adequate ventilation and oxygen perfusion in the tissues to continue aerobic metabolism in the cells, producing CO2. We need adequate circulation in the lungs with proper ventilation so that the CO2 perfuses into the alveoli to be expelled. So this enters the VQ ratio. I'm sure we've heard about it, and I'm sure we've forgotten about it, so let's discuss it here. Understanding the VQ ratio is the gold nugget of capnography. In order to have CO2 transported out of the body, we need adequate ventilation and adequate perfusion. Alveolar gas exchange depends on both the ventilation and perfusion of the alveoli. So this is the VQ ratio, and it needs to be equal. When we apply the VQ ratio to capnography, the V stands for ventilation, and it is equal to the patient's respiratory status, and the Q, which is perfusion, represents circulatory, metabolic, or other pathologies that limit CO2 from reaching the alveolar membranes. When we have a normal VQ ratio, there is a normal respiration, and the end-tidal CO2 values are within normal ranges. You may have heard two different CO2 readings bounced around, so let's discuss the difference. The PaCO2 is the partial pressure of carbon dioxide in the blood. This is measured through lab values from arterial blood work. End-tidal CO2, or EtCO2, is the amount of CO2 we capture in exhaled breath. While PaCO2 and end-tidal CO2 should be close in value, there is generally a difference between the two values of around 1 to 5 millimeters of mercury, and that's normal. During disease process, the difference between these two readings can indicate the severity of the pathology. This is a more advanced understanding and skill that we're not going to dive into today, but it opens up a whole other box of fun if you want to go digging. So we are going to stick with end-tidal CO2 today. By measuring EtCO2 and respiratory rate with each breath, capnography provides instantaneous feedback on the clinical status of the patient. Respiratory rate is measured directly from the airway, and capnography can be used to assess unresponsive patients ranging from those who are actively seizing to patients in cardiac arrest. Unlike pulse oximetry, capnography does not misinterpret motion, artifact, and it provides reliable readings in low perfusion states. Remember these colorimetric devices? The colorimetric was designed to give a quantitative end-tidal CO2 reading, but it was only able to do this for us once. It was useful in confirming placement of our airway devices, but otherwise it was pretty useless. So this is why they've been removed from truck and are now swimming with the fishies. So let's catch a waveform. Capnography is the ideal measurement we want to utilize. To obtain this measurement, we use capnographs. Not pictured is a mainstream capnograph that has a CO2 sensor in between the airway device and the breathing circuit. What we use are side stream capnographs. A side stream capnograph have the CO2 sensor located in the main unit, which in our case is located inside our zowl. And the CO2 is aspirated from a sampling tube connected to a T-piece adapter located between the airway device and the airway circuit, or the sampling line is connected to a nasal cannula device. The nasal sampling cannula that we have on truck is very versatile. You can use it on its own without administering any oxygen, or while you are delivering oxygen to a patient via the nasal cannula. Or I want you to consider using that nasal sampling cannula while you have an NRB on that patient. It can sit nicely under that NRB, and the extra O2 that's being delivered from the NRB will not affect the end-tidal results at all. The T-piece adapter, for those patients that you are creating a CPAP-like seal for, or providing ventilations with an eye gel, let's utilize capnography. Again, we're getting instantaneous feedback on the quality of the ventilations being provided and how well any treatment we are providing is affecting that patient. We won't get used to capnography or become comfortable with it unless we use it and apply it to our clinical decision-making process. Let's look at the waveform and everything we can learn from it. First off, the normal EtCO2 level is between 35 and 45 millimeters of mercury, and this signifies adequate ventilation and perfusion. However, there are some pathologies that will create a new normal a little below or a little above our normal. Such patients are COPD patients. Hypercapnia is classified as anything above the normal range. Hypocapnia is anything below the normal range. And you're able to quantify this amount on the vertical line of the capnogram. So what is the waveform itself telling us? Not only is there value in the numbers provided, but the characteristics of the waveform are highly informative as well. By assessing the waveform, a comparison can be made to the patient's physiology and assist with differential diagnosis and treatment decisions. There are many physiologic waveforms that paramedics will encounter while monitoring a patient. going through the waveform, we have phase 1, which is the wave from baseline representing inhalation, or when there is no or low CO2 being expelled. We have phase 2, which is the beginning of exhalation, where we have anatomical dead space filling with alveolar gas and the alveoli, from the alveoli and the bronchioles. This is transitioning from phase 2 to 3, and it's called the alpha angle. The alpha angle can be used to assess the VQ ratio, and VQ mismatches, we'll discuss this in a minute, will have an alpha angle greater than 90 degrees. Phase 3 is the alveolar plateau, where the last is the CO2 sample and the quantity we are measuring. So transitioning from phase 3 to 0 is the beta angle, and the angle greater than 90 degrees here can indicate rebreathing. And then we have phase 0, which is the inspiratory downstroke. So as soon as we start to inhale, we see decrease in CO2. Now, knowing what waveform capnography can tell us, let's look at how to interpret waveform capnography. And we have a mnemonic for that. What's one more? This mnemonic will help us remember the parts to assessing the waveforms. PQRST is an easy way to help you remember to look at the proper quantity, rate, shape, and trend of a waveform. So what is proper? Consider the reason you're monitoring the patient and what the targeted treatment is for this patient. If you're ventilating the patient, is there proper placement of the biad? What is the quantity? Normal values we talked about are between 35 and 45 millimeters of mercury. But we also have to keep in mind that there are some pathologies that have a high normal or a low normal. Examples include the COPD patient and intubated patients with increased intracranial pressure. Is the rate affected? Consider age-appropriate normal respiration rates. Is the patient spontaneously breathing, or are you ventilating for them? What is the shape like? Normal being a rounded rectangle with a near flat line depicting apnea. Are any treatments needed to correct this irregular shape or the underlying pathology? And is there a trend? Is the trend suggesting improvement with treatment, or do you need to change the current treatment strategy? We can see almost instantaneous effects of the treatment when they do begin to work. So we're going to look at a few waveforms throughout the rest of the presentation so we can see how this applies. So earlier we talked about the ventilation and perfusion ratio. So let's go back to that for a minute and let's talk about what happens when there is an imbalance of this ratio. This imbalance occurs between ventilated alveoli and pulmonary perfusion, and this causes a ventilation perfusion or a VQ mismatch. There are two things that cause these mismatches, the first being dead space and the second being shunting. When we talk about dead space, there are three types. First being anatomical dead space. Remember that this is phase 1 of the waveforms. The anatomical dead spaces are areas of the respiratory tract that do not contain alveoli, that being the trachea, bronchi, and bronchiole. The second dead space we're going to talk about is the airway equipment used in ventilation. And then the third is focusing on physiological dead space. This is where we are really concerned about that mismatch. The alveoli that lack capillary blood flow and cannot transport either O2 or CO2. So this is good ventilation, poor perfusion, and this can be caused by cardiovascular shock, which is decreasing blood flow to the lungs. Emphysema, we have enlarged alveoli, there's less surface area and fewer alveolar capillaries. And pulmonary embolus, blood flow is blocked by a blood clot. And then talking about shunt, it's adequate perfusion but poorly ventilated alveoli, and the CO2 cannot be expelled. This can be caused by pneumonia or pulmonary edema, and this is when alveoli are filled with fluid. There is tissue trauma, so there's alveolar swelling, reducing that exchange of gases, an atelectasis, which is collapse of the alveoli. There's also mucus plugging, and again, air cannot enter the alveoli. In shunt, we have good perfusion, but poor ventilation. So VQ mismatches are then categorized into respiratory, circulatory, or simultaneous mismatches. Respiratory VQ mismatch is due to change in ventilation when perfusion is normal. Think of the patient experiencing either hyperventilation or hypoventilation. Hyperventilation is increased respirations, which lead to increased exhaled CO2, which leads to low end tidal CO2. The waveform begins to shorten due to the increased respiratory rate and shorten exhalations. Decreased in amplitude is due to the excess exhalation of CO2, and this is increase in respiratory rate and an increase in tidal volume. Hypoventilation is a decreased respiratory rate leading to CO2 retention. This leads to a higher end tidal CO2 number. Waveforms begin to grow in amplitude, reflecting CO2 retention, and lengthen due to prolonged pauses. There's a decreased respiratory rate and a decreased tidal volume. Circulatory metabolic VQ mismatch. So there's a change in the Q or perfusion, while the V ventilation remains normal. Assuming that normal respiratory rate and respiratory status, changes in end tidal CO2 levels can indicate a possible circulatory and/or metabolic cause. So there's trauma, hypovolemic shock. This is decreased perfusion. So there's decreased end tidal CO2, and this can also be noted in other forms of shock, such as cardiogenic. Metabolic acidosis. There's fluctuation in the end tidal CO2 from the bicarbonate levels changing and their effects on the CO2 production. So you would see values of less than 30 for end tidal values. And then there's metabolic alkalosis. This can be from prolonged vomiting, hyperthyroidism, hyperadrenergic states, which is a rare phenomenon. And high end tidal CO2 is present in normal respiration rate and tidal volume and free from respiratory pathologies. So let's always rule out respiratory causes when we see high end tidal CO2 numbers. And finally, the simultaneous VQ mismatch, because nothing can ever be simple. Many diseases cause the circulatory, respiratory, and/or metabolic components to simultaneously contribute to changes in end tidal CO2 levels. Think of a patient with pulmonary embolism. They'll be hyperventilating to compensate for hypoxia, thus decreasing the end tidal CO2, but will have compromised pulmonary perfusion due to the clot in the pulmonary vasculature, further decreasing end tidal CO2. It's very difficult to distinguish the difference between respiratory, circulatory, and metabolic contributions to changes in the end tidal with capnography alone. We have to use end tidal CO2 values as another tool in our clinical assessment to correlate the reading with other clinical signs and symptoms of our patient history. I'm hoping you're still with me. If not, hit pause, take a moment, take a brain break, because we're going to talk about the applications and use of capnography for a few different pathologies. So I'll see you back here in a few minutes, or on to the next slide. So first, let's talk about the rundown of the most obvious use of capnography we are all used to, cardiac arrest. We are measuring our resuscitative efforts as well as observing for ROSC, which is cardiac output and pulmonary blood flow. The better the end tidal levels measured during chest compressions, the better the cardiac output. Higher end tidal values during CPR correlate with increased ROSC and survival. The higher the end tidal is, the better the quality of CPR is being performed, and this leads to a better perfusion being produced by compressions. All of this leads to a better chance of patient survival. So this is why we focus on BLS and high quality chest compressions. We can combine the end tidal CO2 to measure how the body is responding to CPR. Values of 10 millimeters of mercury and greater indicates that there is perfusion with chest compressions. We may also notice that there are waveforms present to correlate with chest compressions, and this is an indication of passive air exchange between ventilations. Another positive feedback for the compression rate. Values are going to vary from patient to patient. The main goal during resuscitation is to maintain an end-tidal CO2 minimum of 10. A common question is, why do I have such a high end-tidal in my arrest patients? And we're talking between 40 and 50. Well, when the patient is down for a while, we have a buildup of CO2 that needs to be blown off. Further, it's an indication of excellent metabolism at the cellular level, indicating optimal chest compressions and ventilations. When we notice the values beginning to drop, we need to troubleshoot. This is where the CPR feedback comes in and where we need to correct any deficiencies to ensure good quality chest compressions. This means ensuring compressions are proper depth, compressions at the proper rate, and allowing for full chest recoil. If all of that is effective, are you tired? Let's switch out compressors. Let's make sure that we're switching every 2 minutes at that pulse check. While assessing the quality of CPR, it's also important to ensure the efficacy of positive pressure ventilations. When utilizing end-tidal CO2, we can easily keep track of our ventilation rate, as respiration rate is displayed on our Zoll monitors. Discontinuation can be one of the most difficult decisions a paramedic can make, but there are a number of what-ifs that we're plagued with. When paramedics utilize end-tidal CO2, we have one more supporting factor when it comes to making that decision of discontinuing resuscitation. Data has shown that when paramedics are performing high-quality CPR, an advanced airway is in place, and the end-tidal CO2 reading is persistently below 10 millimeters of mercury after 20 minutes of resuscitation, this is an indication that discontinuation of resuscitation should occur. The end-tidal CO2 remaining low despite any attempts to correct is telling us that there isn't effective perfusion to any organs. So, ROSC, return of spontaneous circulation. How do we get there, but how do we stay there? You guessed it, we talked about it. Good, high-quality chest compressions. During a resuscitation, you notice that there is a sudden spike in the end-tidal CO2 value. This is often the first sign seen when ROSC has occurred, even before a palpable carotid pulse. Now, when this sudden increase is seen, this doesn't mean we stop compressions. We need to continue our chest compressions and ventilations until the next pulse check. And when we do check for that pulse, you can feel a pulse. So what next? The patient is in ROSC, and these patients are at great risk for re-arresting within the first 10 minutes. There are a few things to keep in mind. First, the initial end-tidal CO2 will be elevated above normal range from CO2 retaining during CPR. So ensure to titrate ventilation rates and tidal volume to try to maintain an end-tidal between 35 and 45. While the pulse may be palpable and you have obtained vital signs, continue to watch that end-tidal CO2 value. One of the first signs of a patient rearresting can be seen when the end-tidal begins to decline despite attempts to correct. If end-tidal CO2 is abruptly lost, the first thing you should do is check for a pulse and intervene accordingly. Waveform capnography provides real-time information about perfusion and ventilation. This information provided before, during, and after cardiac arrest should be utilized to make clinical decisions about what to do next for this patient. So trending gives us a continual feedback on whether the patient is improving or not. Cardiac events, pacing, tachycardias, myocardial infarctions, we can assess perfusion status with capnography. This is a continuous monitoring of perfusion status that is not inhibited by movement or our blood pressures, performing 12 lead, pulse checks, etc., and are only snapshots of time. Cardiac perfusion changes will affect end-tidal CO2 levels, assuming circulatory compromise is the only etiology at work. While you are monitoring a tachycardic patient that seems to be compensating, you observe a normal end-tidal CO2 with adequate vitals. If this patient begins to decompensate, a continuous monitoring of end-tidal CO2 can alert you to the lack of compensation much faster than obtaining blood pressures or other signs of decreased perfusion. In this case, you would see a drop in the end-tidal CO2, a drop in the waveform amplitude as the patient's perfusion decreases. For circulatory issues, you want to see the end-tidal CO2 increasing or trending in the higher direction as you apply your treatments. For example, on a symptomatic bradycardic patient that you've begun pacing, you'll observe an increase in the end-tidal CO2 with mechanical capture. Bronchial constriction. So we've all heard reference to the shark fin, and the shark fin waveform is a diagnostic indicator to bronchial constriction as, say, ST elevation would be to an MI patient. Along with presentation of shortness of breath, possible audible wheezing, and/or accessory muscle use, we now have a waveform capnography to assess the severity of bronchospasm and how well our patient is responding to treatments. During the bronchospasm, there are prolonged exhalation, so think of causes of bronchospasm or obstructive airway diseases. This could be asthma, COPD, chronic bronchitis, emphysema, or partial airway obstruction. These are all pathologies with extended exhalation phases, and this extended expiratory time leads to the blending of phase 2 and 3 until they are hidden within each other on the capnograph. The more phase 2 and 3 slur together, or the steeper the slow, the more severe the constriction. This is where we have to combine our patient's clinical presentation and the indications of the capnogram waveform. There may be patients with long-standing obstructive airway disease that will normally or naturally have a slight slope to phase 3 without signs of symptoms of bronchospasm. Mild asthma will often result in lower than normal end-tidal CO2 levels with minimal waveform shape changes as the patient initially hyperventilates to compensate, decreasing end-tidal CO2 values. As asthma worsens, end-tidal CO2 will be within normal ranges as we observe a steeper slope for phase 3 as the shark fin develops. Eventually, in severe asthma attacks, end-tidal CO2 will increase above normal levels and we will see a classic shark fin or shark wave appearance. Not only can we see these type of changes in our patient and predict their disease trajectory, but we can utilize capnography as we intervene. For the asthmatic patient, what medications are we administering? Well, bronchodilators. So after administering the medication, we'll be able to appreciate not only by the patient's clinical improvement, but now also the waveform capnography. You'll observe that shark fin returning to a normal waveform, and we'll see that plateau returning. It helps us see if our patient is improving or if we need to start thinking about moving toward other modalities of managing this patient's bronchospasm. Epi, steroids, magnesium, CPAP. So this is a VQ mismatch caused by respiratory. When we talk about our COPD patients, emphysema, or chronic bronchitis patients, these patients all suffer from chronic CO2 retention, which result in higher end-tidal CO2 quantities than that of our asthma patients. As well, their baseline waveform will be of the shark fin variety. COPD exacerbation will consistently present with higher CO2 levels and a shark fin waveform, and that's as long as there's no other compounding factors involved. If you compare that to our asthma patients who present with a lower end-tidal CO2 initially. Chronic bronchitis is a characteristic of increased mucus production in the bronchioles, and a shark fin waveform will be seen. Emphysema patients, emphysema is caused by alveolar damage, resulting in the downslope of the wave, kind of like a reverse shark fin. The gas exchange surface is so poor and the compliance of the lungs so abnormally increased that the alveolar gas exchange, it happens very rapidly. The air may not expel completely, so we see a downsloping of the wave. And how about that VQ mismatch of these two pathologies? Chronic bronchitis, there is a respiratory problem as the mucus plug or mucus plugs the bronchioles, and we can't effectively move gas in and out. And as for the emphysema, because the alveoli are damaged, it's a perfusion issue at the pulmonary level. So a cool little fact is that CO2 diffuses through fluid at the same rate as it does through air, which is not true for oxygen. So because of this, in CHF patients, the waveforms are normal shape. Even in the presence of a cardiac asthma, that coughing, wheezing that occurs with left-sided heart failure, we will still have a normal shape. Cardiac asthma is caused by hydrostatic pressure between pulmonary capillary beds and the alveolar membranes. This is not caused by bronchial constriction like other type of asthma is. End-tidal CO2 will be low due to the decreased perfusion of cardiogenic shock. And as we actually have a simultaneous VQ mismatch in most CHF patients, this causes because of the tachypnea as well as the decreased perfusion. You can rapidly assess the end-tidal CO2 trends with respiratory failure, providing sufficient information is available to determine whether the patient's ventilation is worsening despite treatment. In respiratory distress, we're either increasing end-tidal CO2, stabilizing end-tidal CO2, or decreasing end-tidal CO2. One of the most important trends we're observing is acute respiratory distress leading to respiratory failure. Generally speaking, at the beginning of the patient's course of illness, we'll see tachypnea with a low end-tidal CO2. Yes, the photo says PaCO2, but we can still use this image for a reference and think of it as end-tidal CO2. As the patient develops further obstruction, we see that increase in end-tidal CO2. Eventually, the patient will become so fatigued that breathing rates slow down, and they develop hypercapnia, and we see an extremely high end-tidal CO2. The rebreathing phenomenon occurs as the patient isn't able to expel their CO2 fully during exhalation. As an example, increasing end-tidal CO2 would reflect in worsening ventilations of an acutely tachypnic patient with obstructive lung disease who is developing respiratory muscle fatigue or more severe lower airway obstruction. For patients who present with high end-tidal CO2 readings, a decrease with treatment indicates that they are getting better. No change or a rising end-tidal CO2 level indicates that the respiratory effort is still failing to adequately eliminate CO2, and other interventions are needed. A patient receiving supplemental oxygen may need CPAP, and patients whose end-tidal CO2 rises with CPAP may need assisted ventilations with a BVM. End-tidal CO2 levels that are greater than 70 millimeters of mercury in patients without COPD indicate respiratory failure. Respiratory failure leads to hypoxia and usually ends up with having a patient intubated, trying to reduce hypercapnia and ensure oxygenation. Correction of hypercapnia while receiving mechanical ventilation is a complicated process. Hypoxia is a true emergency, but hyperventilation with a BVM does not help correct it any faster. Hyperventilation with a BVM is actually harmful because it doesn't allow enough time for exhalation, which worsens air trapping from bronchoconstriction and can lead to lung injury. Hyperventilation also increases intrathoracic pressure, which decreases venous return and cardiac output. This is essentially harmful in CHF patients whose cardiac output is already compromised. Waveform capnography has been shown to reduce the incidence of hyperventilation while we ventilate patients in respiratory arrest. Each squeeze of the BVM generates a waveform and displays feedback on respiratory rate. So let's use the end-tidal CO2 to guide the ventilation to patients in 10 to 12 ventilations per minute and deliver only enough tidal volume needed to make the chest rise. It's also important to allow patients to exhale completely before delivering that next ventilation, even if the respiratory rate must be lowered to achieve this, which can be monitored by viewing the length of the capnography waveform. Waveform capnography is a reliable tool to help make accurate treatment decisions and adapt to conditions changing. When we start to observe a decrease below 35 millimeters of mercury while we are ventilating, This is indicated that we need to slow our respirations to avoid hypocapnia. We're ventilating too fast, so we're blowing off too much CO2. And conversely, we need to observe for an increase above that 45 while we're ventilating, because this indicates that we need to speed up our ventilations to avoid hypercapnia. With intubated patients, we need to monitor that tube location. We know that end-tidal CO2 can confirm the initial biad placement, but continuous capnography monitoring of placement is another advantage to ensure that we are ventilating our patients appropriately. If the biad is properly placed, there will be an end-tidal reading after each ventilated breath. If we see a loss of waveform or changes that don't appear to be fluent with exhalation while we are ventilating, this could be an indication that we need to troubleshoot what is going on. And again, another mnemonic to troubleshoot the loss or the changes of the waveform. So is the tube dislodged? Do we see complete loss of waveform? So is that tube still where it needs to be? Obstruction, do you see changes in the waveform? So has the patient vomited? Is there mucus present? So does that patient need to be suctioned? Pneumothorax, a change to the waveform. So is there a pneumothorax happening? The mechanical function of the lungs is decreased, so let's take a listen to those lung sounds and see if we can hear anything. And then equipment. So is our end-tidal CO2 sampling line still plugged in? Did we turn it on, or did somebody accidentally turn it off? And if in doubt, remove the tube. While maintaining patients who are intubated, there are a couple waveforms that we need to be watching for as well. The Currar cleft, which is seen in the alveolar plateau, is actually a patient making an attempt to breathe. So while ventilating a patient, if you see this, it means that you need to check your patient's breathing status. While the patient's feeble inspiratory efforts are there, some gas or fresh gas is sucked into the tubing and goes past the capnometer, generating this pattern. We'll have to assess if the patient is ready to be extubated or if we need to provide some sedation. We also look into the rebreathing pattern, not only for intubated patients, but patients on NRB and on CPAP as well, run the risk of having CO2 re-enter the breathing circuit. There will be a rise in the waveform baseline as not all the CO2 is being exhaled. This is the most common in intubated patients, but possible to be observed in patients being treated with CPAP. If seen, ensure that the breathing circuits are not malfunctioning. This includes operator error of the BVM and ensuring that the patient has time for a full exhalation. Slow down the respirations. CPAP settings may need to be adjusted when rebreathing occurs, and adjust the PEEP or the oxygen flow. Looking at the patient with increased ICP and trauma prognosis, CO2 levels are a compounding factor for our patients with head injuries. High CO2 levels result in cerebral vasodilation, and low CO2 levels result in vasoconstriction. During sustained hypoventilation, where PaCO2 levels are greater than 50 millimeters of mercury, the high CO2 increases blood flow to the brain. So can you see how that would be detrimental for someone with increased ICP pressure? The cerebral vasodilation brings in more blood, which increases the pressure in the cranium, and this can harm brain injury patients. If we go the other end of the spectrum, and hyperventilation is when we have a PaCO2 and level less than 30 millimeters of mercury, the low CO2 decreases blood flow to the brain, which is also detrimental to the head injury patient because it's now creating a hypoxic state. So we have to find that happy spot for that patient. Instead of ventilating to titrate SpO2 levels, ventilate to titrate your end-tidal levels to achieve a normal level. Continuous end-tidal CO2 monitoring in trauma patients is recommended to further prevent any brain damage. When faced with an opiate overdose patient, the combination of airway management, assessment of oxygenation and ventilation, as well as the administration of naloxone can be the life-saving components of a successful treatment. So first, a little pathology to get us on the right track. The opioid binds with specific opioid receptors in the brain, spinal cord, and GI tract. These receptors are stimulated to mediate analgesic effects by preventing the ascending pain signal from reaching the brain. This will cause a decreased perception of any pain and a euphoric sensation. Opioid toxicity or overdoses occur when too many opioid receptors have been stimulated by the opioid agonist. The clinical effects normally produced by opiates are intensified and exaggerated. This includes the loss of protective airway reflexes. It can lead to respiratory depression, which then leads to respiratory arrest. And this is all due to the brainstem being unable to respond to the rise in CO2 levels. So I know what you're thinking, let's get the Narcan. But first, there's a few steps we need to do before we try to reverse that opiate effect. For the patient with a pulse, can the patient be easily roused by verbal or tactile stimulation to unresponsive stimuli? What is the quality of their ventilations and perfusion? Do we need to intervene? Are the ventilations effective? So capnography can provide a window into the efficacy of the patient's respiratory status. An opiate overdose patient can present with an elevated EtCO2, increasing as the respiratory drive is depressed. It's not unusual to see extremely high numbers, such as 100, with an opiate toxic respiratory distress. So now let's talk about naloxone and capnography. By utilizing capnography monitoring during naloxone administration, we can effectively titrate the dose of Narcan or naloxone required to reestablish adequate effective ventilations and a respiratory rate. That's the goal of naloxone after all, right? Paramedics want to avoid total reversal of the opiate overdose due to the threat of the patient experiencing withdrawal seizures, possible vomiting, and possibly the patient becoming combative or violent. We don't want them flying off the floor. Prior to administering naloxone, ensure airway management with the use of an OPA, NPA, BVM, oxygen. Hook up the capnography sensor to the Zoll. Get your reading and titrate respirations to facilitate an end tidal to normal ranges and increase oxygenation. Do not administer Narcan until you correct the hypoxia and the hypercapnia. A hypoxic brain upon awakening is what causes these combative, confused patients. Administering naloxone in a smaller dose increment in just that little pinch is just enough to produce effective respiration rates and ventilation. When observing for Narcan effect, the positive end tidal CO2 feedback can be appreciated faster than relying on the visible chest rise, oxygenation, and change in responsiveness. Capnography can also indicate when the effects of the naloxone is beginning to wear off. So you've given the patient some Narcan, brought up the respiration rate, and it's a nice end tidal of 40. Keep your patient on the capnograph or the nasal to trend your patient while en route to the emergency department. Because due to the duration of action of naloxone being less than that of the opiates, the likelihood of readministration of naloxone is high. Watching capnography will allow us to maintain the desired quality of respirations, allow us to titrate naloxone with complete return of respiratory distress, arrest, and without fully reversing the opiate overdose. So continuing on with that respiratory depression from an opiate, anytime we sedate our patients, we run the risk of causing respiratory depression. Capnography can rapidly detect the common adverse airway and respiratory events associated with sedation, including that respiratory depression, the patient becoming apneic, upper airway obstructions, laryngospasm, or bronchospasm. Respiratory depression can be caused by oversedation, and this will manifest with abnormally high or low end-tidal CO2 well before pulse oximetry detects a failing oxyhemoglobin saturation, especially in patients receiving supplemental oxygen. This may be tricky to apply to a patient considering the situations we can be using Haldol or midazolam for, but capnography utilization when we're administering antipsychotics, benzodiazepines, and opiates is a consistent monitor of the ABCs. It really just makes life that much easier for us. When it comes to monitoring our hyperglycemic patients, we're using end-tidal to detect metabolic acidosis and ensure their intrinsic respiratory rate is compensating for acidosis. Here we are seeing a simultaneous VQ mismatch from hyperventilation and physiological dead space from decreased end-tidal CO2. Capnography can be used to differentiate a hyperglycemic patient versus a patient who has reached DKA and metabolic acidosis. High blood sugar with end-tidal CO2 being normal, 35 to 45, has yet to progress to DKA as the bicarbonate levels are still adequate. A high blood sugar level with an end-tidal CO2 level less than 30 is likely headed into DKA. Additionally, Kussmaul's respirations have developed which also continue to drop the end-tidal CO2. Knowing this helps understand where our patients are on their disease trajectory. There's a positive linear correlation between serum bicarb, which is HCO3, and end-tidal CO2 in patients with diabetic ketoacidosis. ETCO2 decreases because the compensatory increase in minute volume resulting from a decrease in serum bicarbonate. The more acidotic the patient becomes, the lower the serum HCO3 is, and the greater the respiratory rate, the lower the end-tidal CO2. As we are trending the hyperglycemic patient, a decline in end-tidal CO2 would indicate a progression to acidosis or worsening acidosis. Now, what if we have a patient that has a respiratory rate of 48 but an end-tidal of 7? Should we attempt to correct the patient to normal? Seeing a hypocapnic patient might make you want to jump in and intervene, but the key to successful management of these patients involves supporting intrinsic respiratory efforts. Non-invasive positive pressure ventilation is crucial to maintaining the pH of the patient. They are expelling as much CO2 as possible to compensate for metabolic acidosis. So it's almost impossible to match their physiological respiration pattern with a BVM or a ventilator. Assisting breaths or NIPPV to assist in oxygenation and CO2 expulsion is critical in maintaining the patient's pH level. Maintain their intrinsic rate can be accomplished by CPAP, BiPAP, or assisted ventilations with the BVM, with or without an iGel. Some patients may have a well-maintained airway, and application of passive oxygenation with BVM and PEEP will open up the alveoli more to allow for better ventilation. We may need to start to see the end-tidal trend upwards on these patients. This is not a good thing. It indicates that the patient is decompensating and you'll have to intervene. If it comes to the point where you need to provide active ventilation, bag fast, however, lower tidal volumes. Low to moderate PEEP, so that's 5 to 8, and try to keep your end-tidal CO2 low. Aim for whatever reading you had initially, because that is what the patient needs to blow off as much CO2 as possible. If we don't facilitate that, then they will die. Along the lines of metabolic acidosis, let's have a quick talk about sepsis. Like DKA, there is a prolonged metabolic acidosis, which is depleting the bicarbonate levels, causing acidosis and increasing ventilations, which lowers end-tidal CO2. According to the new surviving sepsis guidelines, there is a new criteria to distinguish sepsis from septic shock. Sepsis criteria are as follows: signs of decreased end organ perfusion, clinical suspicion of infection, hypotension, which is systolic less than 90 or a MAP less than 90, temperature which is greater than 38.3 or less than 36, a heart rate of greater than 90, or tachypnea at greater than 20. Patients with these will also present with a pCO2 of less than 32 or an end-tidal of less than 35. There is an inverse relationship between end-tidal CO2 and lactate levels in sepsis, and end-tidal CO2 performs similarly to lactate as a predictor of mortality in patients with suspected sepsis. These patients are compensating for their metabolic acidosis by increasing respirations, which is decreasing the already decreased end-tidal CO2. Presenting with a simultaneous VQ mismatch because of the decreased perfusion and hyperventilation. So at the end of it all, end-tidal is a very diverse tool for monitoring our patients, from spontaneously breathing to patients who are in respiratory or cardiac arrest. It's a rapid, continuous metering of patients' perfusion, helps us determine patients' response to treatments, and it ensures that we are ventilating efficiently. It also provides us with prognostic indicators, such as the patients with hypoglycemia, hyperglycemia, and in septic shock. Get used to using the end-tidal CO2 on a regular basis. So often I've heard that people are saying, oh, I forgot it again. So make sure you build it into your assessment, that it becomes second nature. If you're going to put oxygen on this patient, let's put the end-tidal CO2 on. If anybody has any questions after this video, please make sure that you reach out to any of the clinical educators on their cell phones here. Thank you for sticking with us today, and have a great day.